Good morning. I call this hearing to order. Subcommittees are here today to examine how the expansion of telehealth services may benefit small businesses and rural communities. Telehealth or telemedicine refers to the use of online, video, or telephone communication to deliver healthcare services that either replace or supplement existing healthcare services. Telehealth is becoming a vital component of medical treatment, particularly in areas where there are provider shortages, such as rural areas where I'm from, or for conditions that require regular monitoring. While 20% of Americans live in rural areas, only 9% of physicians practice there. Rural communities often struggle with provider shortages, requiring patients and their families to travel long distances to access medical care. Telehealth may allow rural physicians to expand their patient base and to keep dollars in the community, benefiting other local small businesses, such as retail establishments and restaurants, contributing to the sense of community that American small towns pride themselves on. Expanding use of telehealth services may even attract physicians to open or relocate practices in rural areas without worrying about having enough local patients to stay in business. Those of us from rural areas would not want to live anywhere else, yet new physicians often have concerns about opening a viable practice in a rural community. Our witnesses today will discuss the current use of telehealth and the barriers that are providing wider use. I want to thank all of them for being here today. We look forward to hearing your testimony. And I now yield to the ranking member of the Subcommittee on Agriculture, Energy, and Trade, Mr. Snyder, right on cue, for his opening statement.
Thank you, and I'm sorry I'm late. Elevators. Anyway, I want to thank the panelists for being here and taking the time to share your thoughts with us about healthcare coverage for rural America. Today, rural populations are more likely to be poor, sicker, older, and have higher rates of uninsured compared with urban populations. Exacerbating these issues, rural Americans experience many difficulties in accessing healthcare services, which leads to higher morbidity and mortality rates compared to those of their urban counterparts. Among the primary challenges rural communities face is a lack of adequate insurance coverage or even getting coverage at all. Nearly 1/4 of all adults in rural communities are uninsured, and nearly 60% of the rural uninsured are low-income families. Rural populations are less likely to have employer-sponsored health insurance. Consequently, Medicaid is a critical lifeline for rural and underserved communities. This is why efforts to repeal the progress the Affordable Care Act has made to provide coverage to underserved and rural communities is so misguided. In addition, there is a shortage of doctors and hospitals in rural areas, and institutional barriers can make providing care in these areas especially challenging. These challenges not only result in poor health outcomes for people in rural communities, but have significant implications for the local economy. I look forward to hearing testimony today about policies that can increase the number of physicians in underserved communities and leverage technological innovation to improve health access and quality. Policies that increase insurance coverage not only benefit patients, but also create jobs in the healthcare sector, a sector that is overwhelmingly comprised of small businesses. In fact, it is estimated that since 2012, 50,000 jobs were added to the healthcare sector as a direct result of the expansion of coverage under the Affordable Care Act. Despite this growth, there still remains a significant provider shortage in rural areas. Even with insurance coverage, many patients in rural areas struggle to find care, especially when it comes time to visit a specialist. The fact is made abundantly clear by the ongoing opioid epidemic currently plaguing our nation. It's estimated that as many as 3 million people in the U.S. are suffering from opioid addiction related to prescription drugs and heroin. As opioid-related deaths have gone up across the nation, the largest increases are reported in heavily rural states. Our constituents and their families need help, but they often have no place to go. For example, 13% of rural communities have no behavioral health providers. Telehealth has the potential to bring high-quality behavioral health services to these suffering communities. Indeed, studies have shown that video telehealth users have satisfaction levels and outcomes similar to those clients receiving in-person therapy. Although it's still in its early stages, telehealth is expanding at a rapid rate and has the potential to dramatically improve access to quality care in a number of areas. Telehealth also has the potential to draw more doctors into practice in rural settings who would otherwise feel isolated, and can be used to connect specialists with community providers, allowing practitioners to join a virtual community where they can receive mentoring and grow professionally. Improving access to care in rural areas also benefits the local small business economy. There are over 1,500 rural hospitals nationwide that support nearly 2 million jobs. Every dollar spent by a rural hospital produces $2.29 of economic activities. When patients can receive care in their community, they do not need to travel to urban centers. They're able to keep their dollars within their own community and help to drive the success of local small firms. I look forward to hearing testimony today about how we can advance policies and leverage telehealth to improve access to quality health care for rural and underserved communities. With that, I say thank you and I yield back.
Thank you, Mr. Snyder. I'd now like to yield to the ranking member of the Subcommittee on Health and Technology, Mr. Lawson, for his opening statement.
Thank you, Mr. Chairman, and welcome to the committee. Thank you. 19% of the U.S. population live in rural areas, most of you know, yet only about 9 or 10% of physicians practice in rural areas. Rural population has fewer hospitals, healthcare providers, particularly specialists, than any other urban counterparts. And patients often must travel long distance, as we heard earlier, to access, while primary care providers struggle to coordinate care with specialists. This is not only has implication for doctors, clinics, and small hospitals, but for local small businesses, economy. However, innovation and technology are helping to alleviate the strain on small providers. Today's hearing will offer an opportunity to examine ways that we can improve access to health care in rural areas. Telehealth has the potential to advance health care quality while reducing costs. It can save patients time and money in traveling to see the doctors, while also allowing small practice to broaden their scope. This also indirectly benefits local small business economy by keeping dollars in the community and making rural areas more attractive. I myself grew up in a rural area. In recent years, innovations have made telehealth technology more accessible to rural providers than ever before. However, obstacles to its adoption remain. Some barriers are easy to overcome, such as educating doctors and patients about its utilities. Other obstacles, such as the lack of broadband connectivity, are more challenging. I am pleased this hearing will provide the opportunities for us to examine not only the barriers to health faced by rural communities, but how innovation and technology can improve them. I hope that this hearing will help us identify ways we can encourage greater adoption of telehealth and how improve access to care benefits small business economy. I want to thank our witnesses again who traveled here today for both your participation and insight into this important topic. With that, Mr. Chairman, I yield back.
Thank you, Mr. Lawson. If committee members have an opening statement prepared, I ask that it be submitted for the record. I'd like to take a moment to explain the timing lights to our panelists. You will each have 5 minutes to deliver your testimony. The light will start out as green. When you have 1 minute remaining, the light will turn yellow. And finally, at the end of your 5 minutes, it will turn red. And we ask that you try to adhere to that time limit to the extent possible. I'd now like to formally introduce our witnesses today. Our first witness is Ms. Nikki Clowers, the Managing Director of the Healthcare Team at the U.S. Government Accountability Office, or better known as GAO. The healthcare team at GAO recently released a report entitled Telehealth and Remote Patient Monitoring Use in Medicare and Selected Federal Programs, and surveyed a wide variety of stakeholders on the state of telehealth use in federal health programs. Thank you for being here with us today. Our next witness is Ms. Barb Johnston, the Chief Executive Officer and co-founder of HealthLink Now in Sacramento, California. Ms. Johnston's company helps mental health providers incorporate telehealth services into their practices. Additionally, through a Centers for Medicare and Medicaid Services grant, her company integrated telehealth services into more than 80 primary care clinics in 3 rural states, Montana, Wyoming, and Washington. We appreciate your testimony and being here today. And I now yield to Mr. Kelly, a member of the full committee, for the introduction of our next witness.
Thank you, Mr. Chairman. And I'd also like to just acknowledge that the chairman of the full committee, Chairman Chabot, has joined us, and we thank him for being here on this important event. Thank you. I'm proud to introduce Mr. Michael Adcock, the administrator of the Center for Telehealth at the University of Mississippi Medical Center, or UMMC. As executive director for UMMC's Center for Telehealth, Michael is on the front lines of combating the severe doctor shortage that Mississippi faces. The UMCC Center for Telehealth is, in my opinion, the best in the country and leverages location within Mississippi's only teaching hospital to deliver high-quality care to rural patients that often lack access. Mr. Adcock, I'm excited to have a great Mississippian here today, and I look forward to hearing your opening statement. Thank you, Mr. Chairman, and I yield back.
Thank you, Mr. Kelly. I now yield to our ranking member, Mr. Snyder, for the introduction of our next witness.
I'm going to yield to my colleague, Mr. Lawson.
Thank you, sir. Okay, I have the pleasure of introducing Dr. Shoemaker, President of the National Rural Health Association, Professor and Chair in the Department of Family and Community Medicine at University of North Dakota School of Medicine and Health Science. Dr. Shoemaker have spent nearly 20 years in rural practice and teaching residents and students in the area of medical education, rural health, and workforce research. He has acted with both the American Academy of Family Physicians, serving on the Commission on Quality and Practice with the WACO, the Global Association of Family Physicians, serving as the North American representative to the executive of the Group of Rural Practices. Welcome, Dr. Shoemaker.
Thank you, Mr. Lawson. I'd like to now recognize Ms. Clowers for her 5-minute testimony.
Chairman Blum, Ranking Members Schneider and Lawson, Chairman Chabot, and members of the subcommittee. Thank you for inviting me here today to discuss our April 2017 report on telehealth. Access to healthcare services can be challenging for some people, such as those who live in remote areas. Telehealth can provide an alternative to healthcare provided in person or at a doctor's office, for example, by providing clinical care remotely through two-way video. In my comments today, I will cover 3 topics from our April report. 1, the extent to which telehealth is used in Medicare and Medicaid. 2, factors that affect the use of telehealth in Medicare. And 3, the different payment and delivery models that could affect the potential use of telehealth in Medicare. First, we found that Medicare providers use telehealth services for a small proportion of beneficiaries and relatively few services. For example, an analysis of Medicare claims data by the Medicare Payment Advisory Commission, or MedPAC, shows that less than 1% of all Medicare Part B fee-for-service beneficiaries access services using telehealth in 2014. According to MedPAC, beneficiaries using telehealth averaged about 3 telehealth visits in 2014, and Medicare spent about $14 million in total in telehealth services in that year. The most common telehealth visits were for evaluation and management services, followed by behavioral health services. MedPAC's analysis shows that 10 states accounted for almost half of all Medicare telehealth visits. For Medicaid, the use of telehealth varies by state, as individual states have the option to determine whether to cover telehealth and what types of telehealth services to cover, among other things. We reviewed 6 states to gauge the extent to which telehealth is used by Medicaid. We found that officials from states that were generally more rural than urban said they use telehealth more frequently than officials from more urban states. For example, Montana officials told us that they have used telehealth as a tool to help patients see both in-state and out-of-state specialists remotely, as there is a limited access to specialists in the state. In contrast, officials from Illinois, which contains more urban areas, told us that telehealth represented a very small portion of their Medicaid budget and was used primarily to provide behavioral health services. Second, stakeholders that we interviewed identified factors that encouraged the use of telehealth in Medicare, including the potential to improve or maintain quality of care, address provider shortages, and increase convenience to patients. For example, telehealth can increase convenience by shortening or eliminating travel times, which may lead to better adherence to recommended treatments and to patient satisfaction. However, these stakeholders also identified several potential barriers to the use of telehealth in Medicare, including payment and coverage restrictions. For example, Officials from one provider association reported that Medicare's telehealth policies for payment and coverage, such as those restrictions that limit the geographic and practice settings in which beneficiaries may receive telehealth services, are more restrictive than the policies of other healthcare payers. Finally, as of April 2017, CMS was supporting 8 models and demonstrations that have the potential to expand the use of telehealth in Medicare. For example, one demonstration aims to develop and test new models of integrated health care in sparsely populated rural areas. Under the demonstration, CMS allows participating providers to receive cost-based payments for telehealth when their location serves as the originating site, rather than the approximately $25 fixed fee that CMS otherwise pays originating sites. In summary, while the use of telehealth in select federal programs is low, it remains an important alternative to providing healthcare services in person, especially for patients who cannot easily drive long distances for care. Chairman, ranking members, and members of the subcommittee, this concludes my prepared remarks. I'd be pleased to answer questions at the appropriate time.
Thank you, Ms. Clowers. Now recognize Ms. Johnston for 5 minutes.
Thank you. Honorable Steve Chalbert, Chairman Blum, and other members of the subcommittee. My name is Barb Johnston, as announced.
Can you move closer to the microphone or move it closer to you? Thank you.
Does that work better? Okay, so sorry. I've been working in telemedicine for so long now, I'm thinking of lying. It's been over 20 years. It's been a labor of love. I've learned so much along the way. Today I'm here as a private citizen. I am doing that because I've been working in so many different areas. I wanted to cover lessons learned from so many of the opportunities I've had to work, primarily serving people in rural areas. As mentioned before, the core problem for rural medicine is 15% of the Americans who live there are only served by 10% of the nation's doctors. Telemedicine has been around for a long time. Some of you may not know, but psychiatry, telepsychiatry has been practiced for 50 years, half a century. So far, there are some key things I wanted to share with you that have been demonstrated and that people have already mentioned, but I want to bring it up again. Telemedicine has shown and has massive capacity to keep rural dollars in rural communities. It supports rural primary care providers and clinics. It helps keep hospitals and clinics open. Without the support of specialists through these modalities that are so commonly used in our everyday life, such as using our cell phone, which is just a mini computer, or banking or education. People in this country expect to be able to use technology to receive appropriate and high-quality care using telemedicine. And it's happening. It's happening all over the country. It's growing. It encourages recruitment and retention of the local doctors and providers who do serve physically in person in rural communities. Many, many studies, work that I have done, continues to show it does lower the overall cost of care. It can actually avoid small businesses closing. A person who owns a small business or a worker in a rural community who has to travel 3-4 hours outside has to shut down that business that day. It costs them so much money and is so unnecessary. They lose wages, and the community may lose the barber shop, the only restaurant in town. It also helps support health IT workforces. Every program I've ever started has included people in rural communities learning to use these technologies. And one thing you all should know, rural people are very smart. They catch on very quickly. They're brilliant at putting these things together. I think we all know that the cost of healthcare in this country is significant. It's growing. Telemedicine has the capacity to help resolve some of that financial burden. There are laws and regulations that could help significantly I'm identifying three that are crucial. Number one is the problem we have with the DEA rule related to a 2008 bit of legislation called the Ryan Haight Act that inadvertently prevents our doctors providing the medication that they need, so that when a telemedicine service is provided, specifically affects three groups: opiate addicts who need the medication. The doctors are not allowed to do the prescription online. All the doctors that we work with use electronic health records. They can't provide the drugs that these opiate addicts need. Our veterans, and I've seen a lot of them, they cannot receive the basic medications they need for PTSD, traumatic brain syndrome, just because of an inadvertent inclusion in that DEA rule. That could and should be changed and corrected. Children with ADHD, they lose school days. They can't pass because they can't get the medication they need. One of the biggest problems we've had since Medicare instituted the rural requirement, this limits patients with Medicare who live in geographic locations that are defined by, in my opinion, very narrow rural designation. They can't receive Medicare services. Those constituents are getting more and more upset. They're seeing these things on TV. They know telemedicine exists. Medicaid doesn't have these rules, but Medicare does. And the last one is the complicated credentialing licensing problems. I'm seeing my time run out, so I will leave where I am because I hit the key elements, and I'm grateful, very honored to be allowed to present to you, and thank you so much for your consideration on this important topic.
Thank you, Ms. Johnson. We're grateful that you're here as well. Mr. Haddock, you're recognized for 5 minutes for your testimony.
Thank you. Chairman Chabot, Chairman Blum, Ranking Member Schneider and Lawson, and members of the Small Business Committee, thank you for the opportunity to appear today. I am Michael Adcock, Executive Director for the Center for Telehealth at the University of Mississippi Medical Center in Jackson, Mississippi. I'm honored to talk with you this morning about telehealth and the ways its power can be harnessed to address the healthcare needs of America's small businesses. Mississippi has significant healthcare challenges, leading the nation in heart disease, obesity, cardiovascular disease, and diabetes. These and other chronic conditions require consistent quality care, a task that is made harder by the rural nature of our state. In order to improve access to care and give Mississippians a better quality of life, it is clear that we need something more than traditional clinic and hospital-based services. Telehealth has been a part of the healthcare landscape in Mississippi for over 13 years, beginning with an aggressive program to address mortality in rural emergency departments. This program has had a significant impact not only in bringing quality care to the residents of these communities, but in supporting the viability of the community hospitals themselves. In some cases, teleemergency prevented hospital closures that would have been detrimental to these underserved communities. Today, the UMMC Center for Telehealth delivers care in over 200 sites in 68 of our state's 82 counties and provides access for patients who might otherwise go untreated. Maximizing our utilization of healthcare resources through the use of technology is the only way that we can reach all of the Mississippians who need care. Small businesses account for 99.9% of all firms in the United States and often cite access to healthcare as their number one concern. Decreasing absenteeism, increasing productivity, and improving access to high-quality care are concerns to small business owners and were the drivers behind the creation of our e-corporate program at UMMC. This program allows employees to access high-quality care from their workplace through secure audio-visual connections, avoiding travel to seek medical care and promoting appropriate use of healthcare resources at a lower cost. Several corporations have chosen to pay for this service for their employees and allowed paid time during the workday to use the service, further reducing barriers to healthcare. Should an employee have a need outside the scope of telehealth, UMMC assists in securing appropriate follow-up with local providers. The e-corporate program currently covers more than 4,000 employees and dependents statewide. We offer wellness services and diabetes prevention management services for corporations as well. Another program that has been very impactful for patients is remote patient monitoring, which supports patients as they manage these chronic diseases in their home. RPM is designed to educate, engage, and empower patients so that they can take care of themselves. Our initial pilot with diabetics in the Mississippi Delta was a public-private partnership to test the effectiveness of remote patient monitoring using technology in rural underserved areas. The preliminary results showed a marked decrease in blood glucose, early recognition of diabetes-related eye disease, reduced travel to see specialists, and most remarkably, no diabetes-related hospitalizations or emergency room visits among our patients. The Mississippi Division of Medicaid extrapolated this data to show a potential savings of $180 million per year if 20% of the diabetics in Mississippi on Mississippi Medicaid participated in the program. Given the success of this diabetes pilot, UMMC Center for Telehealth has expanded remote patient monitoring statewide. Healthcare is a major economic driver across the United States, and this has already been discussed. In Mississippi, hospitals boast over 60,000 full-time employees and create an additional 34,000 jobs outside of their facilities. For every new physician creates approximately 21 jobs and more than $2 million in revenue for a community. For every 3 jobs created by a hospital, an additional job is created by other businesses in the local economy. Our telehealth program directly supports the financial viability of the healthcare system, especially primary care providers' offices, small rural hospitals, and rural healthcare clinics. Keeping services in the communities not only supports the local providers, but keeps much-needed employment and revenue in the rural communities. Businesses in Mississippi that have utilized our telehealth and remote patient monitoring programs have seen improved access to care, decreased healthcare costs, and improved quality of care for their employees. Healthy employees mean decreased absenteeism, increased productivity, and a greater chance for small businesses to remain viable. Thank you all for your time and attention to this very important matter.
Thank you, Mr. Adcock. And for some reason, you are a little easier to understand than my good colleague and friend, Mr. Kelly from Mississippi. So we appreciate that. Dr. Schmitz, you are now recognized for 5 minutes.
Good morning, Mr. Chairman, ranking members, and members of the subcommittee. Thank you for inviting me here to testify. My name is David Schmitz, and I'm a family physician who has practiced and taught in rural America for more than 20 years. I am here today representing the National Rural Health Association, where I currently serve as president, and I'm grateful to have this opportunity to discuss rural health care and its impact on rural America and local economies. For 62 million Americans living in rural and remote communities, access to quality and affordable health care is a major concern. Rural Americans on average are older, sicker, and poorer than their urban counterparts, as we've heard. They are also more likely to suffer from chronic diseases that require ongoing monitoring and follow-up care. Local care is necessary to ensure patient ability to adhere to the treatment plans to help reduce the overall cost of care and to improve patient outcomes and their quality of life. Whether following the delivery of a healthy baby or significant loss of function due to stroke, local integrated care for rural people in their own support systems is not only the right care, it's better care. Rural communities are resourceful, and the continuity of care is primary to good outcomes such as avoidance of hospital readmissions. Investing dollars locally can save what would otherwise be wasted dollars lost to inefficiencies, anonymity, and the gaps that occur in the miles between. There's no doubt that rural health care delivery is challenging. Workforce shortages, older and poorer patient populations, geographic barriers, low patient volumes, and high rates of publicly insured Medicare and Medicaid recipients, uninsured and underinsured populations are just a few of the barriers. Unfortunately, a growing number of rural Americans are living in areas with limited health care options. Indeed, 81 rural hospitals have closed since 2010, leaving many rural Americans without timely access to emergency care. Two of the most recent of these, closing on June 30th of this year, were in Florida and Texas. As noted in my written testimony, health disparities between rural populations and their urban counterparts are pronounced, and this can be particularly true among the growing minority populations in rural America. Rural health care providers are not only critically important for health of rural Americans, they are also critically important for economic health of rural communities. While many industries in rural America have been shrinking, healthcare is an industry with potential to reverse declining employment. As factory and farming jobs have declined, the local rural hospital often becomes the hub of local business community, not only offering critical life-saving services, but representing as much as 20% of the rural economy. Simply put, hospitals provide a large number of jobs. The average critical access hospital creates 195 jobs, generates $8.4 million in payroll annually, and rural hospitals are often the largest or second largest employer in a rural community, along with the school system. This was true in the community I practiced in of 2,303 people for 6 years. In addition, a single rural primary care physician, again, as we heard, can generate as many as 23 jobs and more than $1 million in annual wages, salaries, and benefits. In my own personal experience, rural communities are both resourceful and resilient. As referenced in my written testimony, training doctors and other health professionals close to home makes it more likely that they will call that place home. In order for this to occur, we must have technology across a rural distributed campus, per se, training our workforce to meet the needs of rural communities and at the same time providing economic investment in those rural places. Graduate medical education or residency training regulatory reform allowing for education of physicians in rural hospitals is one example of how to address rural economic development and workforce shortages in one action while improving quality of care and delivering cost-saving health care. Technology. Technology such as telemedicine for consultation services have supported rural delivery of care, but depend on adequate development of broadband internet into rural and remote areas. Still, hands-on care is needed when an unexpected car accident or early delivery of a premature baby occurs in rural America. No matter if you're a local resident or simply visiting, each one of us will spend our time and dollars in rural communities, and at those times will appreciate quality local care in those moments. In addition to these life-saving measures, healthcare is one industry capable of playing a critical role in supporting the local economy and protecting rural communities from further economic damage. If roads and internet access are the blood vessels and the nerves, then in my opinion, healthcare is the backbone for investing in rural America. Thank you again for the invitation to speak and to accompany my written testimony as submitted.
Thank you, Dr. Schmitz. And I now yield to the chairman of the Subcommittee on Health and Technology, Ms. Radewagen, for her opening statement.
Thank you, Mr. Chairman. I want to apologize for being a little bit late. I was on the Senate side testifying on behalf of the Secretary Zinke's Assistant Secretary for Insular Areas, which is our areas. So, Talofa, good morning. Thank you, Chairman Blum, and thank you all for testifying today. Good morning to Chairman Shabbat as well. It's an honor to chair the Subcommittee on Health and Technology, and I look forward to learning more today about how both health and technology can benefit small businesses and rural communities. According to recent data from the Kaiser Family Foundation, American Samoa is facing tremendous shortages of primary health care professionals and is currently only meeting around 10% of need in terms of the number of physicians available to serve the population. The Samoan Islands have among the highest rates of obesity and type 2 diabetes in the world, with 1/3 of American Samoans suffering from diabetes. If medical treatment is unavailable on the island, patients, including many VA beneficiaries, generally have to fly nearly 3,000 miles to Hawaii to see a specialist. Recently, CMS granted a waiver that will allow Medicaid patients to go to New Zealand instead. That's been helpful. I'm very interested in hearing and learning more about strategies for increasing the use of telehealth in rural and remote areas like American Samoa, where provider shortages are severe. I also look forward to hearing more about how telehealth could attract more new or current physicians to locate their practices in rural areas like American Samoa, where the tropical scenery, rainforests, beaches, and reefs are second to none. I want to thank all the witnesses for being here today, and I yield back my time to Chairman Blum.
Thank you, Ms. Radewagen, and thank you for that commercial at the end. We agree with you. I now recognize myself for 5 minutes of questions. I love this topic. I think the increase in costs in healthcare in our country are not due to one large thing or two large things. I think, and pardon the pun, it's death by 1,000 cuts. The increased costs are because of 1,000 smaller things. And I also think the solutions is not one silver bullet to solving increased access and decreased cost while keeping our quality high. There's not one silver bullet. I think it's 1,000 smaller things, if you will. I absolutely believe one of those smaller things is telemedicine. This is for the whole panel, ideas of where the federal government is the largest purchaser of healthcare in the country, obviously. I'd like to hear from you places the federal government can increase the outcomes, the quality of the outcomes, increase access, decrease costs by utilizing telemedicine that we're not doing today? Give me 2 or 3 great examples of here's where we could save money and increase and improve the outcomes for patients. Anyone? Dr. Schmitz?
Thank you, Mr. Chairman. Just a couple of brief examples. One is you've heard the use of tele-emergency medicine. Again, how can you develop a relationship between for example, family physician in a critical access hospital being able to be simultaneously supported both in their practice, which retains them and also lowers the barrier to recruiting to rural areas. At the same time, the transfer, if necessary, is expedited with high-quality care. Another example is tele-ICU or intensive care unit consultation, allowing, again, patients to stay in place when possible. A third example is something called Project ECHO, which is a learning group where you can have essentially development of teams across the spectrum of disease, including opioids, to be able to develop better practices across the country. And my final and fourth would be, again, the use of technology and telemedicine in distributed medical education and health professions education, training people as close to home as possible.
So these items you just mentioned, Doctor, are not being done today?
To a certain extent they are, but there are also opportunities with regard to reimbursement mechanisms and regulatory mechanisms that would allow this to be expanded particularly into rural areas. One example I mentioned was graduate medical education funding and residency funding reform, allowing, again, more cost-based reimbursement or more support of these both workforce initiatives as well as healthcare delivery mechanisms.
Thank you. Are there others? Ms. Johnston?
Thank you. I think that the market has potential to drive expansion massively if the handcuffs could come off, and I mean that in reference to my earlier remark. The limitation of the location of a patient being rural or not rural, it actually doesn't make any sense to me. It doesn't make sense to constituents. When you have a neighbor who has Medicaid, they can see a doctor, and their next door neighbor has Medicare and they can't, and that conversation's growing. I'm an active member of the American Telemedicine Association, so I hear it from my colleagues all over the country. If that one thing could get corrected, I think the market would drive expansion and it would help business in this country. The other place is in skilled nursing facilities. Skilled nursing facilities primarily are caring for our elderly, some disabled, and in those facilities, almost all of the ones that we have approached, even when I was in the position of having millions of dollars to fund programs, which I did, I couldn't get one nursing home to accept starting a program for fear that there would be an incorrect billing and they'd be doing fraud, or because they would have some of their clients not being able to access care and they didn't want to look like they were preferentiating one group over another.
Mr. Adcock?
Yeah, another area that's not currently being paid for through Medicare, not being reimbursed with Medicare, is remote patient monitoring. So chronic disease management in patients' home, as we know, Medicare recipients are often struggle from many chronic diseases, not just one, but diabetes, heart disease, and that's something that we can impact through remote patient monitoring. Right now, there is not a payment mechanism for remote patient monitoring through Medicare.
Do you feel this would actually save the government money?
I
can see
absolutely-
where it would improve the outcome.
Yes, I mean, similar to what we've done in Mississippi with Medicaid, and Medicaid, obviously, in Mississippi is funded by federal and state dollars. There's a tremendous savings just in diabetes. So yes, we're performing this service in congestive heart failure, hypertension, asthma, COPD. There are many different chronic modalities that are costing a lot of money and a lot of our healthcare resources that can be taken care of in the home through technology.
Thank you. I know my time has expired. I now recognize the ranking member, Mr. Snyder, for 5 minutes.
Thank you, Chairman Blum, and thanks again to the witnesses for being here and sharing your perspective. Mrs. Johnson, I just want to say you should not be hiding the fact that you've been working this area for so long, but wearing it as a badge of honor because it is critical. And I'll also say, you mentioned that we've been doing telehealth and psychiatry for 50 years. One of the things that struck me is the phone was patented. I had to look it up, but the phone was patented in 1876. As we have new technologies, I don't want to wait 100 years or 90 years to start using them again. Much of the conversation is often around telehealth filling gaps. For rural communities, there are gaps in care. Mr. Adcock, I think as you were talking about what you're doing in Mississippi, it's creating opportunities to improve healthcare, improve its efficiency, lower its costs, and have better outcomes. And I hope over the course of time we can move our conversation from filling the gaps to really finding ways to use telehealth to make a difference. And I think the rural communities and the small businesses, as you discussed, provide that great opportunity. So I'll get off my soapbox, but I did want to just emphasize that. Dr. Schmitz, you said you've been in this area for a long time. We hear about the shortage of doctors for so long. Earlier this year, I was privileged to introduce the Conrad 30, reauthorization of the Conrad 30 program, which would bring doctors from other countries into our rural communities, helping to fill that gap again. But I'd be curious from your experience if you've seen that program and other programs of graduate medical education to support doctors coming into where the need is the greatest. Share your thoughts, please.
Thank you, Ranking Member Schneider. I appreciate it, the opportunity to answer. We have seen benefits. There's no doubt about the need that we have from a provider workforce standpoint in rural America. And I think programs as such you have mentioned have been an important opportunity to be able to serve those needs. I actually have done research looking at the recruitment of rural providers into both several states here in the United States, as well as comparing that to other countries such as in Australia. And I think as we look at a global need with regard to, as you said, not only beginning to have an adequate workforce in place, but really have a healthcare team that provides the most efficient and effective care to people, that advent of technology has really changed the dynamic. Not only do we see doctors who still do house calls, but we also see physicians and really healthcare teams that can deliver everything from occupational therapy to dietitian services, and most critically, mental health services locally as a team through use of technology and local providers. It's still about the relationship between, isn't it, between the patient and the provider, between a couple of neighbors in a small town. That really, I think, to a certain extent, impacts the quality of care and some of that efficiency. But supporting those providers as teammates and the use of technology has really changed the dynamic. And I think the example of health monitoring, where patients are empowered to be able to then access local health care and subspecialty care as needed, can change the fabric of what that appears to be. That will draw graduates from all over the world, I think, to appreciate what it means to be part of a rural community and a provider in those communities.
Great, thank you. Mr. Adcock, you talked about your program, and I just want to clarify that I heard it right. Emergency diabetes check-ins went to 0 in the program, you said?
That's correct. The first of the members of the study, they had 0 ER visits, 0 hospitalizations for the first 6 months of the program.
That's extraordinary.
It is.
Are there things you identify that were critical to that? Are there barriers to taking a program like this across the country?
I think the critical the critical success factors were the fact that we didn't just monitor. There are a lot of monitoring programs. Even though we call our program remote patient monitoring, we actually engaged with the patient and provided them education. So I think all the providers I've talked to would agree that if they had the opportunity to educate their patients in small bits every single day and check on them and provide real-time intervention, they would, but that's not realistic. So that's something we can deliver through technology. So that's where they benefited, was learning about their disease process. Diabetes, while it's not complicated to me or some of the providers, it is complicated to someone who is newly diagnosed and doesn't understand what they should eat, what they shouldn't eat, when they should exercise, how much water they should drink. So when you can provide that education in a home daily in small bite-sized pieces, it's extremely beneficial to them. And also when they slip or when they make a mistake and they eat the pecan pie, which we often do, when they check their blood sugar, we know it, and we're able to intervene immediately instead of waiting 3 months for the next in-person visit. So I think it's that relationship and the engagement and the empowerment, teaching them to take care of themselves was the big success factor.
Thank you, and I'm out of time. I just want to add one more comment. Ms. Clowers, thank you for your testimony, but the discussion around the different pilots that you all are doing to take those pilots from success, where there are successes, and getting it out, if there's anything we can do to help, please look to us. And with that, I yield back. Thank you.
Thank you, Mr. Snyder. And I'll recognize the gentleman from Mississippi, Mr. Kelly, who's also our chairman of the Subcommittee on Investigations, Oversight, and Regulations, for 5 minutes.
Thank you, Mr. Chairman. And Mr. Adcock, it's nice to have someone here who does not have an accent. How does Medicare's definition of rural area, and I know Ms. Johnston talked about this too, present challenges for providers wishing to incorporate telehealth into their practices? And specifically, I know in Union County, because one little area is so many miles from a four-way, they don't qualify, but from a four-lane highway. But people don't understand driving distance and miles are different, especially in rural areas. So if you can do that, Ms. Johnson, after him, if you would like to follow up, I would really appreciate that.
We talk a lot about rural versus urban settings and rural designations. What we see in telehealth, and Mississippi is certainly rural, and we have a lot of rural areas. We also have urban areas that don't qualify for as a CMS service. So I'd like to steer the conversation away from geography. The fact is we have healthcare resource shortages. And it doesn't matter. I can tell you a specific example, dermatology in Mississippi. It takes 6 months to get a dermatology appointment in Mississippi. It doesn't matter if you live right next to the University of Mississippi Medical Center or if you live 180 miles away. Geography doesn't matter in that case. So it's more to me about healthcare resource shortages and being able to address those. Those don't always happen exactly the certain distance from a four-lane highway. They happen all over the place. So being able to lose that geographic restriction would be great if we could lessen that or get rid of it altogether. Because the fact is, access to care isn't just about urban versus rural. It is about whether or not there's a resource available and how a patient can access that resource.
Ms. Johnston, briefly.
Oh, thank you. Let me give you two quick examples. Number one, a small town in Wyoming where they have a huge backlog. Patients needed to see a psychiatrist. They absolutely refused to allow us to provide telepsych, an entire program paid for, because they were so afraid of complications with not billing correctly. That's just one example. Second example, we have been recently approached to provide telepsychiatry services to Puerto Rico. They identified 6 clinics. They gave us the addresses. We went online because there's a site under CMS, so you make sure that you're allowed to do it because they require that the Medicares also be seen. Not one clinic across Puerto Rico was considered to be meeting that definition. The program cannot go forward. I've been to Puerto Rico. I've driven all over it. I still can't find the non-rural area.
And that being said, Mr. Adcock, I want to ask this question, but I think it's important. It's more economy driven than it is rural or urban. There are a lot of inner city areas that have the exact same issues that rural areas have. They have the exact same travel distance or challenges that a rural area would have. And I think it becomes about people who are a lot of times impoverished, who don't eat well and who are not educated in what those diseases are and are a long distance in time or access from medical. And I think we owe it to them to get medical access, and I think telehealth can do that. That being said, Mr. Adcock, what are the benefits of small businesses offering telehealth in the workplace?
I think, again, it's access. It allows access for employees who may not have access to health care otherwise. It also forms that relationship. So once they start seeing a provider and we're able to refer them to a local primary care physician, it completes that relationship. And the earlier they can get access to care, the more likely they are to recognize a disease, whether it be prediabetes, whether it's diabetes, hypertension, could be eye disease, any other disease. So early access is important, and limiting those barriers. So a lot of employees are main providers for their home. They're not able to take off half a day to go to a physician's office, and they may have to drive 40, 50 miles to the physician's office, wait in the waiting room, be seen, and they've missed half a day of work. They have to pay their copay. They'll just be sick. And employees who aren't well aren't productive. It's not good for the small business. So being able to decrease absenteeism, increase productivity is extremely important for those small businesses and could mean the difference between keeping them viable or not.
And just in closing, Mr. Chairman, I'll just say telehealth is the way to the future. We know preventative medicine is one of the primary cost-saving benefits that we get in America, and using technology to get that to it's a no-brainer to make sure that we use this and maximize this for small businesses and for our medical care. Thank you, and I yield back.
Well said. Thank you, Mr. Kelly. I now recognize the gentleman from Florida, Mr. Lawson, who's also the ranking member on the subcommittee on health and technology for 5 minutes.
Thank you, Dr. Smith. Rural America includes approximately 57 million people and about 20% of the population. There are 1,855 rural hospitals that support nearly 2 million jobs. How does improved access to care in rural areas benefit the local economy?
Thank you, Congressman. You're exactly right that, again, the testimony that I've provided in writing it and accompanying here with you is that local hospitals are a driver of the local economy, not only directly with regard to employment of physicians that results in economic stimulus and further jobs, but also with regard to keeping the opportunity for growing other businesses local. Again, I've had experience in North Dakota, but also now 20 years of experience in Idaho, and I can remember times when during difficult fiscal discussions, we talked about roads and we talked about healthcare and we talked about education because we knew that would bring industry to our small towns. That was an economic driver in itself, but also built, again, a framework upon which we could see economic growth. So I would commend the opportunity to speak with you and agree on the fact that rural hospitals, and at this point in particular in time, saving rural hospitals, recognizing not only their cost effectiveness to quality care, but also the fact that they're an economic driver in our nation is a timely discussion. Thank you.
And Doctor, I'm going to ask you this question simply because I was involved in it. It is in 2000, we in the legislature in Florida authorized a medical school at Florida State. And the key factor in authorizing that medical school is that they were going to train physicians to go into rural areas, and other people might want to comment on that. So that's been 17 years later. But what I understand is a lot of the students, once they finish, because of tremendous loans and stuff in medical school, they want to go into the cities where they can make a little bit more money to take care of medical loan. Have you seen in medical schools, have this philosophy changed, and have we worked out anything to cause them to go into rural areas?
Thank you, Congressman. That has been the study of my last 10 or 15 years since leaving rural practice myself, but staying in contact with rural medicine as a medical educator. I think you're right that we have found that intentional public accountability with regard to medical education is key, and training in interprofessional health teams is also important. One of the things that I've seen is that we train to have people remain. That I could say, being from the country, from the sticks, training in the sticks. And one of the things that we've found is that studies that we've actually done, including rural training track residency education, where we actually have physicians training during their residency in rural places such as critical access hospitals, have a higher likelihood that those physicians will remain in rural and underserved communities. So I think those sorts of investments and the opportunities to look at regulatory relief or funding, and then encouraging, again, our medical schools to have these sorts of tracks for rural providers shows that that is the evidence, is that where they train, they're more likely to remain. This accompanied by loan repayment opportunities, both at the federal and state level, and mentoring, frankly, mentoring of physicians so that they can see themselves there, especially now in the advent of the utilization of technology, where now we can see our patients are supported to be self-empowered around their disease conditions. But frankly, I think that I can tell you as a 29-year-old doctor in an ER, it's a little bit scary. And you want to do the best you can, and you know you will do the best you can, but having an opportunity to have that consultation and mentoring, not only in person and in practice with your partners, but also through telehealth, makes a powerful statement to our young students.
Since you have been at it for a very long time, do you see any difference in whether it's really working in the training of in medical schools, a physician to go right into the rural areas?
I think one of the strategies that we've done in the state of California, I served on the board of trustees for the Health Education Foundation, and what that sought to do, and has been very effective, We provide loan repayment for primarily physicians, but other healthcare workers who will serve in rural areas. That's about been the most effective thing we've ever done, because some of these students get out, they owe $150,000, and to get them to go work in a rural area where their income is going to be so much lower than in the urban area, this was a huge incentive, and it has been a very effective program. And we found that if they stay in the rural community for 2, 3, 4, 5 years, much higher percent that they will stay there.
Okay, and I yield back, Mr. Chairman.
Ms. Clowers, did you want to add on to that quickly?
Thank you. I just wanted to add that we did work issued earlier this spring where we looked at graduate medical education funding, and most of the funding is still going to urban areas. And that is important, as Dr. Schmidt says, because where people train, they tend to stay. And also what we found is that the efforts, federal efforts to increase graduate medical education in rural areas is limited. And really that funding is driven by statute. So I just wanted to add that for the subcommittee.
Thank you. Thank you, Mr. Lawson. The gentleman from Kentucky, Mr. Comer, is recognized for 5 minutes.
Thank you, Mr. Chairman. I have a question for anyone on the panel, just out of curiosity. I assume you all kept track of both the House healthcare bill and the Senate healthcare bill. And I'm curious, did either of those bills affect telehealth in any way, either positively, negatively, or no impact whatsoever? Anybody know? You don't know. What about a complete repeal? That's something that's obviously being batted around now in the Senate and in the House. Would a complete repeal have any impact on telehealth? A complete repeal? Anybody know?
I can only imagine that if millions of Americans lose their health insurance, it's going to have an impact on this nation, and it for sure is going to impact anywhere healthcare is provided.
But there's no specific part that that you can think of that would have a. I mean, you just assume that.
I would agree with that. Probably the best source to get that specific answer would be through the American Telemedicine Association. They have staff that are specifically looking at this, and we can follow up and get that information to you from the ATA.
Well, I certainly support telehealth. Being in a rural part of Kentucky, it's very challenging for our hospitals to get physicians, and this is very important, and we want to certainly support that. And hopefully we can work together and fix our broken healthcare system. There are parts of healthcare that are working. There are parts that I think need to be radically changed. The cost of healthcare is a big issue that doesn't seem to be getting a lot of attention now. It's all about health insurance, but hopefully we can come to a solution, and look forward to staying in contact with you all as we try to fix our broken healthcare system. And certainly for those of us that represent rural areas, telehealth is a very, very important part that I want to support, and I'm sure everyone on this subcommittee does as well. Thank you, Mr. Chairman.
Thank you, Mr. Comer. The gentleman from Kansas, Dr. Marshall, is now recognized for 5 minutes.
Yeah, thank you so much, Mr. Chairman. A great topic, something I'm pretty familiar with. I think, first of all, always talking about success stories. Colby, Kansas, Citizens Hospital, part of a stroke collaborative program that Dr. Bobby Mosier has piloted in Kansas. One of the greatest success stories I've ever seen, very dependent upon telemedicine. A person has an acute onset of a stroke, and if we can give that thrombolytic agent within 30 minutes, we talk about cost savings. So what's about cost savings? The true cost savings that this makes is in the healthcare dollars we're not going to spend. This stroke person that we prevented the stroke from becoming permanent, we just have saved hundreds of thousands of dollars of hospital bills, rehabilitation bills, and then a person that's maybe on a disability the rest of their life. So that's the beauty of this. We could talk about strokes, we could talk about acute MIs, again using that thrombolytic agent. And what people don't understand is these agents have very significant side effects. And it takes a lot of courage to give this drug. And if you don't give it on a regular basis, you just don't give it, especially not in time. The nurses drag their feet. So Colby, Kansas is hooked up 24/7 to another busy ER. And a nurse can take the patient's symptoms and why the nurse practitioner is scrambling to get over there, walks into the room, and everything's already set up and going. They've got a protocol set. We're getting the CAT scan, and within 30 minutes, we can give that drug, and it's night and day. Another great success story in Kansas is the Kansas Enhanced Veterans Service Program. It's a mobile office that goes across the state. 22 veterans die from suicide every day in this country. Those veterans are not going to come to the Veterans Hospital, both of them we have in Kansas. So we're taking the program to them. They're using telemedicine to touch base with their psychiatrists, their psychologists, their social workers back home, making sure they get their medicines. Absolutely a success story. My thoughts would be is that government will not solve this problem, but rather innovation will continue to solve the problem, and Medicaid or Medicare typically get in the way of solving the problem. So I would continue to look for success stories and then try to not reinvent the wheel, but keep accentuating those. So I would ask for anyone, what are the most, I shared my success stories. We can't use a shotgun and try to use telemedicine for everything, but it has some great opportunities in the emergency room, and I think the psychiatry as well. So does anyone have a great success story they want to share? Dr. Schmitz, you have one?
Thank you, Congressman. Again, I would just share a success story around tele-ICU. And what that is essentially is in, again, a critical access hospital that otherwise can provide appropriate care. I've certainly been in the situation where we were frankly weathered in. We were concerned about the safety of having a helicopter land in our town because of snow or other conditions. Also similarly concerned, what would a patient be able to do with regard to ground transport for safety? In my town, there were 104 curves in a 19-mile piece of road on the way out to the urban center. And so I think you're exactly right. And one thing we can look at is how do we have consultation through telemedicine with, for example, patients who may or may not need to be transferred the next morning and oftentimes actually don't need to be transferred. Again, providing not only quality care, access to care, but in a fairly common scenario, better care, and
Right.
really empower that team.
I've been in that same position so many times with a 25-week baby, 600-gram baby, and fogged in, snowed in, and scrambling to try to fix that problem. I can certainly deliver the baby, but the problem was taking care of the baby afterwards. Any other great success stories that you have? Ms. Johnson, go ahead.
I was PI on the Patient-Centered Medical Home Project that was a program funded through CMS's CMMI Innovation Initiative. And during the 3 years that we ran it, 2012 to 2015, we showed significant cost effectiveness. Just as one example, NIH, their numbers for outpatient, for mental health patients annually averages about $1,557. Ours came out to $390. Patient satisfaction over 90%.
Okay.
It was huge.
Congratulations. So I got 20 seconds. Where's telemedicine not working? Can you give me examples? Anybody where there's an area of medicine that hasn't worked very well?
No.
Yes, sir.
I do think we need to continue to coordinate care so patients have primary care access and electronic medical records are able to integrate patients' global care.
Thank you.
Thank you, Dr. Marshall. The gentleman from Nebraska, Mr. Bacon, is now recognized for 5 minutes.
Thank you very much to all four of you. We got votes coming up, so I'll just get right to the questions, but I appreciate you being here. First of all, a couple of you mentioned the definition for rural areas hurt, telehealth. Is that a regulation or a law? What do we need to change specifically to fix this?
For Medicare, it's defined by statute.
Okay, so it's on us to make that change then.
Correct.
Okay.
And what it requires is requires both in terms of restrictions on the facilities as well as the location. So that certain facilities are allowed in Medicare to be originating site, as
Right.
well as it has to be located in an area that's been defined by HHS as being a health professional shortage area or outside of a metropolitan area.
So that's a task for us to work on then. We'll take that on. Second question, Ms. Clowers, you mentioned the VA using a lot more telehealth. Can you talk a little more about that? Because I know we have a big, long line of people trying to get care, and this is one way to help.
Right. VA, what we found is that 12% of services provided in 2016 were telehealth visits, or 12% of the 12%, which is much greater than what we saw in Medicare. And in fact, what we also found was that they have over 50 different types of specialties or services that are eligible for telehealth, and they have less restrictions than in Medicare. So, for example, the program does allow for the patient to be at home for telehealth visits.
Okay, that's great news. Here's one for any of y'all. Who are the opponents to doing this? Are there industries out there or institutions that are fighting this? Go ahead, please.
I think the world of telemedicine has appropriately been challenged by a lot of really important agencies. The American Medical Association used to be really concerned. I think the concerns all stem from people wanting to make sure that we're doing this correctly, that we're providing quality care. Whenever we get challenged, it's never from somebody who's just saying no. It's just because they need to be educated and reassured that anybody who's using these technologies is meeting, if not exceeding, the quality of care that people deserve.
One last question. It seems that some illnesses are tailor-made for this, but others may be a little more challenging. So what is the percentage, would you say roughly, that this is telehealth is perfect for? But there's other things. Sometimes you got to lay eyes on the infection or what, you know what I'm saying? There's some things a little more challenging where the doctor has to actually see it, perhaps, or take blood or something. I don't know. What do you think the percentages are?
Congressman, thank you for an important question. I think, first of all, and I think it responds to the other question about the pending decisions that will come up around healthcare and access, is in that rural America, we need to have people who can deliver health care and places where it can be delivered. So we look at rural health clinics, federally qualified health centers, private practices, and critical access hospitals as examples. We still need the providers there. If it's an automobile accident and a chest tube is required for a collapsed lung, we still need the providers there. I see telemedicine more to support those services as well as to augment them. And in some ways, telepsychiatry, mental health, we've even seen where patients will be more likely to see a telehealth provider in an adjunct room of the critical access hospital as opposed to sometimes driving down the street a block. I don't know what the future holds, but I don't see one necessarily replacing the other. They really come together.
Well, thank you very much. I yield back.
Thank you, Mr. Bacon. As has been mentioned previously, votes have been called. So this is a very important topic, and we have some members here that still haven't had a chance to ask their questions. So we will stand in recess until after the votes, and then we will reconvene. We shall stand in recess.
Okay, we will gavel our committee back into session and thank all of the witnesses for continuing to stick around. Apologize for the delay, but we did have to do a little bit of what we are here to do a while ago, so which is go vote on some very important legislation to certain people or areas of our country. And I'm Congressman Luke Temeyer. I'm from Missouri. I'm the vice chair of the entire committee. And Chairman Blum has other duties to attend to for the moment, so you are stuck with me to take us out the gate here. So with that, let us continue on with the discussion we're having, and we will recognize Ms. Gonzalez for 5 minutes.
Thank you, Mr. Chairman, and thank you, the whole panel, for staying here so long. Over the last 5 years, over 3,000 physicians have left Puerto Rico. And currently, the island loses 1 doctor per day, as you may know. Hospitals and medical practice groups are finding it very difficult to recruit specialist physicians and experts. We're trying to have some kind of telehealth by medical specialists located in the U.S.-based academic medical centers. Maybe can be a great opportunity for the island, especially in rural areas that are 100% of the island, maybe 90%. Are there any impediments to telehealth payment arrangement when the patient is located at their home in Puerto Rico or at a medical facility in Puerto Rico, and the doctor is at a medical center located on the mainland? Ms. Johnson? Ms. Johnson?
Hi, it's Barb Johnston. Yes, many, and it's problematic. As I mentioned, we've been approached, the company that I currently work for, we have the doctors, they want to work. They have doctors locally that want to learn how to do this locally in Puerto Rico, and we're more than happy to do it. Where the sticking point is getting payment for doing it. As I said before, Medicare's rule that restricts to their definition of rural for telemedicine completely blows the whole project. It prevents us from being able to do that. If there could be some kind of a waiver, or we could be allowed to pilot, or whoever's going to provide the care, because it won't just be telepsych, which is what we do. There are others. But that's the desperate need that we've heard from people in Puerto Rico. So if they could do that, the other is getting a waiver to allow patients to be seen in their home. There are many parts of Puerto Rico where, and we've been told that people don't have transportation. Even if there was some, they can't. And like the Veterans Administration in this country has been doing this for probably 10 years, successfully seeing patients directly at home.
Quick question. That waiver is going to be for federal government or federal, do we have to amend any federal laws, or are we talking about state laws?
I might have.
Defer to Ms. Flowers.
The requirement is through statute. So the statute defines in Medicare where the services can be provided. As Ms. Johnson said, it has to be, the originating site must be in a area that's been designated as a health professional shortage area or outside of a metropolitan area.
In our case, the shortage is there. Actually, we are having the same problems in the VA facilities, the same as American Samoa. We don't even have the specialists in so many areas in the VA hospital, and we're trying to recruit them, but it's so difficult because nobody wants to leave the mainland to go to Puerto Rico or even remote areas to move their families to attend the patients there. And I would like to know if you can provide the whole panel specifically what kind of amendments do we need to make to change that statute. You can provide, I know we in 1 minute you can provide that, but if you can provide that to the committee later on, that will help us a lot to identify those statutes with the correct language, so we don't mess with the whole situation.
And Representative, I would like to add too that in addition to a potential statute change, CMS through their Innovation Center has different models and demonstrations that they can run, and they have the ability to waive certain requirements. And so they would have the ability to have a demonstration and waive these rural requirements, and
I
that might
know.
be something that you would be
I
interested
know,
in.
we're working with them directly. We're trying to change the state plan, and even doing that, we're still facing the same problems. And that's happened with Puerto Rico. That's happened with other states. So this is not an issue just for the territories. But we're facing. I mean, in our cases in the islands, you can't cross the state line. I mean, you can take your car or even take a train. You have to take a plane or a boat to take the service, and that's not enough. So that was the question. And since my time is running, is there any, can you provide information about the security of the patient's records on telehealth, or how secure and private these records are when telehealth is employed?
The way that most of us work, and I'll speak to the company I currently work for, we use a fully HIPAA compliant system end to end. We use a product called Athena Health. I have no investment in it, don't own it. It's just a completely secure and HIPAA compliant system. Anything that we use technology-wise, the video conferencing, the health record, any communication, you can't text. They're very strict. We actually are the only telepsych company in the country that's Joint Commission accredited. That's just part of it, but yeah, end to end.
Same thing. Ours is encrypted and all HIPAA compliant. Everything that we use goes into our electronic medical record, Epic. So it's all controlled just as it would be if you came in person.
Thank you. Ajay Black. Thank you, Mr. Chairman.
Jolie's time has expired. Next we go to Representative Rodawagan from American Samoa. She's the chairman of the subcommittee on health and technology. She's recognized for 5 minutes.
Thank you, Mr. Chairman. Ms. Clowers, American Samoa could greatly benefit from using telehealth for patients to access medical care remotely without leaving the islands. We've talked about it a bit today. However, broadband access is not sufficient. Are there federal programs available to assist remote areas like American Samoa to support broadband for telehealth?
Yes, ma'am, there are, and you're correct. Broadband is a challenge, and it's something that we heard in our work when we surveyed people about the barriers to using telehealth, the infrastructure that's required to successfully carry out telehealth. Broadband was identified as one of those infrastructure challenges. And there are grants that are available for different communities through different departments. And for example, the USDA has grants, and the American Samoa has received a grant, I believe in the amount of $820,000 for support in this area. And we can happy to get you more information on that grant if you're interested.
Thank you. Mr. Adcock, what are some important innovations in telehealth that you've experienced while working in this field, and what innovations may we expect in the future as more American consumers demand telehealth services?
Thank you very much. I think that the innovations that I'm going to go to the second part of the question first. The innovations that are coming in the future, I couldn't begin to tell you. There are so many different wearables and sensors and things that are coming out now that are being innovated now that I can't imagine what the future is going to look like from that standpoint. But I think where we focus on technology is that we wrap technology around our clinical programs. I think that our focus, while technology is certainly important, I think our focus is around the patient and what we need to do to provide excellent clinical care to the patients. And then we use the appropriate technology around that. But being able to deliver care into a home to monitor diabetes so that patients don't have to plug anything in or try to transcribe their outcomes or their results themselves, I think that just in the last couple of years has come so very far. And being able to Bluetooth into these devices and use cellular technology to connect patients and providers has come so very far in the last couple of years. Where it's going, I would honestly be scared to say, but I think that the focus needs to remain on making sure that providers and patients, not necessarily in that order, but patients and providers are the center of what we're doing with telehealth. This should be an extension of healthcare. This should be something that's used to help better healthcare services that can be delivered at home.
Ms. Johnston, would you care to answer that question?
I completely agree. At the American Telemedicine Association annual conference this last year, Thomas Friedman spoke a keynote, and that's really what he was echoing. He stood on a stage and said, right now with 10,000 people in this audience, there's a couple of guys in a garage. And Silicon Valley, and they're ahead of us. We just need to catch up with them. I think it's going to be part of it. I think, too, the current president of the American Telemedicine Association, he has been putting forward and doing a lot of speaking about hybrid healthcare in a model that he sees more and more individual providers and health systems where they see some patients on telemedicine, use remote monitoring, and some in person. And that's happening quite a bit. It's spreading across major hospitals and health systems across the country.
Thank you, Mr. Chairman. I yield back.
I understand the lady from Samoa has a closing statement. You're welcome
Thank
to go
you,
ahead and do
Mr.
that.
Chairman. Well, let me take this opportunity to thank all of the witnesses for their testimony today. As the chairman of the Subcommittee on Health and Technology, it's extremely valuable to hear how telehealth is helping physicians expand the services they offer and is offering patients more convenient options to access the health care they need. American Samoa is facing tremendous provider shortages, and telehealth services could keep our residents and their families from traveling long distances to receive care or going without the care they need. This could also benefit other small businesses by keeping dollars in the community. I was also pleased to learn that there's hope that telehealth will make rural areas more viable locations for physicians to operate their practices. Technology has improved many aspects of daily life, and it can potentially improve healthcare access as well. Fa'afetai te lava soifua. Thank you, and I yield back to Chairman Luchtmeyer.
I'm glad you interpreted that for us. Thank you very much. I will defer my questions to the end. I think Ms. Gonzalez has got a second round question here, so let's go to Ms. Gonzalez, recognized for 5 minutes.
Thank you, Mr. Chairman. I really appreciate that difference. And I will be short. I will just leave you with some questions I got. And one is regarding Mr. Kelly in his statement here, identified the issues regarding rural areas. And one of the concerns regarding Mississippi was the diabetes situation and your experience treating patients with diabetes in using telehealth. How do those patients were improving? Do you have seen a decrease in the hospitalizations and emergency room visits in Mississippi? That's one of the questions, because we got the same situation in the island and another situations regarding heart diseases, among others. That will be one of the questions. I don't want to abuse from the chairman. That will be one of the questions. The second one is going to be in terms of, is there a need for a certification requirement when telehealth providers are located in a jurisdiction other than where the medical provider is located? What are those requirements, if they're from CMS or HHS or whatever they are? If the state is involved in that, and how difficult are those regulations to comply with? And in terms of having, is there any copayment to the patient if they are using telehealth, in terms of the veterans, if they're using this kind of program? I don't know if that's going to be one of the questions.
I'll take the first question around remote patient monitoring, and thank you for asking that follow-up question. Yes, in our diabetes pilot that we did in the Mississippi Delta, we saw significant results in the preliminary results, and the final results will be out later this month. But we saw a decrease in hemoglobin A1C, which is the measurement of blood sugar over time. We also saw a complete elimination of ER visits and hospitalizations for those patients that were on our program. So not only did they just reduce their visits to the ER, we did not have any diabetes-related ER visits or hospitalizations.
Zero?
Zero. Not saying that would be sustained over a huge population, but we have seen very similar results in the final results are very much mirroring that, and the results that we see with our population that's on that program outside of the pilot have had significant results in readmissions and hospitalizations. So that's one of the points of the program, but I think the reasons for that are because of the education that we provide and the real-time interventions. So we teach them about their disease so that they can take care of the disease themselves. You can't expect them to go to a provider every time something is going on. That's not realistic. It's not realistic for the provider. It's not realistic for the patient. So being able to teach them about their disease and then teach them as they're having issues. So if their blood sugar goes up, you're able to intervene at that time and say, this is why your blood sugar went up. This is what you can do to prevent it in the future. A lot of these ER visits aren't due to medical emergencies every time. A lot of times they're due to fear. They don't know what to do when this happens. So being able to educate them in real time has been a real success. And we've spread that program statewide.
Mr. Smith?
Thank you, Congresswoman. I would just like to agree with that testimony and just give a quick example. If we look, for example, as a primary care provider, a family physician per se, at the patient-centered medical home, having a dashboard where information comes in, you can literally have, green, yellow, red, where people who are knowledgeable about this data can then, for example, use what's called open access scheduling and decide who gets an acute care visit, open slot with that provider, be it a physician assistant, physician or otherwise, and avoid, again, that lack of information that otherwise might result in an ER encounter with someone who does not know them as well.
Thank you. Ms. Johnson or Ms. Clovers?
To your second question about other challenges with, excuse me, licensing, when we spoke to different stakeholders through our work, we did hear that licensing was a challenge, and that an example of that is when you're at the distant site. You also, if you're a provider at the distant site, you also have to be licensed in the state that the patient resides, and that can be challenging for different providers, and that's driven by state law.
Thank you. You want to add something, Ms. Johnson?
I was just going to answer. I think you asked a question about a co-payment for telemedicine.
Yes, if there
I've
was.
never actually heard of that.
Okay.
I don't have any experience with that.
Okay.
We've never done anything like that.
Okay. Thank you. With that, I'll yield back. Thank you, Mr. Chairman, and thank you all the members of the panel.
Gentlelady's time has expired. With that, I just want to follow up with a few things. And I know that, Ms. Clowers, you were talking about some of the payment and coverage restrictions that cause problems sometimes. Can these, I know we mentioned, I think it was Ms. Johnson mentioned some of the things that happen and can be done or changed with regards to the locations qualifying. But with regards to payment and coverage restrictions, can CMS do this right now through their rulemaking process, or does this have to take legislation?
The coverage issue would require legislation. It's defined by statute.
Okay.
They do have flexibilities in their innovation center where they're able to test different approaches with different models and demonstrations. So that would be an area that they could explore with a model.
Okay. Some of the things you talked about, do you have studies that show how much it saves?
We do not. When we did our work in looking at the different opportunities and both benefits of telehealth, we were looking at CBO scores, which showed it's hard to tell sometimes in terms of the cost savings. It depends on how telehealth is used. If it's used to replace an in-person visit, that can result in savings. But if it's used in addition to an in-person visit, that can increase costs. So that's what we found in terms of the cost savings. But I know other witnesses here at the table have other experiences.
Yeah, I think, Mr. Edcock, you were talking about your in-home monitoring programs, and did you put an analysis on that, see how much you actually saved with the pilot project you're talking about?
So the pilot project, again, was a public-private partnership, but our division of Medicaid actually took the data on the actual cost savings of those first 100 patients, first 6 months, and extrapolated that to say that if 20% of the Medicaid patients in Mississippi who were diabetic were on the program, we'd save $180 million a year. So yes, there are cost savings.
Your state would save that much?
Yes. Well, I mean, yes. Medicaid would save that much, so federal and state together.
Medicaid program would save $180
Correct.
million a year, just on that one?
Just diabetics, just 20%.
Oh.
So now we're doing hypertension and heart failure and all the other chronic diseases we're monitoring as well. So we'll continue to do cost analysis on those programs. We have legislation in Mississippi that allows us to get paid for remote patient monitoring, so there is a fee to it, and we do receive payment. The cost savings are tremendous.
Okay, and you mentioned a couple other things that you're working on with remote abilities here. That was heart monitoring and what else?
Heart failure, so congestive heart failure, hypertension. We also monitor, that's adult and pediatric diabetes. We're working on asthma and chronic obstructive pulmonary disease. All of these are high-cost items. We also monitor, now this is outside of the reimbursement legislation in Mississippi, we also monitor bone marrow transplant and kidney transplant patients so that we can get them out of the hospital sooner and get them back home.
Now, the hearing today was with regards to rural telehealth, but I mean, telehealth is something that they can utilize, people utilize every day everywhere else too. I mean, urban areas, suburban areas, I mean, this isn't something that is confined with it. But what we're talking about here is the importance of how it helps the quality of life basically for folks in rural areas. And so, Dr. Schmidt, would you like to add anything to the discussion with regards to other opportunities and the cost savings? Have you done any studies or aware of any of that?
I really appreciate the opportunity, Congressman. One example I think that hasn't been brought up is the provision of chemotherapy, for example. As you can imagine, in a rural critical access hospital that's quite remote from subspecialty care, supporting a local physician nurse team, for example, to administer chemotherapy in the same quality really does prevent patients who otherwise would have very uncomfortable transport, not only long transport, but uncomfortable transport during the treatment of their disease.
Okay, so what we're doing is trying to find ways to improve the quality of health in our health services in rural areas, and the things you're suggesting, is anybody putting this into a bill that you're aware of, or just discussed it with you to help work on this? Yes, Dr. Smith.
I'd be happy to follow up with the National Rural Health Association as how telemedicine and technology can be incorporated into better rural.
Because the comment a minute ago was that some of it has to be done legislatively, some of it can be done through the rulemaking process. And I think that's you know, I think we have a friend with Dr. Price at HHS now who's willing to look at options, look at different things, different ways to deliver care, deliver services, upgrade and innovate. But by the same token, if we need to do something legislatively, I think that's where we need to go. But Mr. Adcock?
The Connect for Health Act that's out right now addresses a lot of these issues.
Okay.
It addresses the geography issues, it addresses a lot of the reimbursement issues. So that's something that we fully support and would love to see some more input on that.
Okay, very good. Would any of you like to add? Yeah, Ms. Johnson.
I just want to second that. That legislation is bipartisan. The Connect for Health, it would address most of these things. Another comment I'd like to make, in the CMS grant that we were given, 2012-15, we submitted a final report that showed significant cost savings. Happy to provide that to the committee. The VA every year produces very good data on cost savings, and the American Telemedicine Association is currently collating data on multiple studies across the country on cost savings.
Does the VA coordinate with I guess CMS with regards to telehealth stuff? I mean, your veterans are scattered all over the place. I mean, and they network back usually to a VA facility of some sort. Does that help them or hurt them with access to care? Or are you familiar with that?
I don't know if the VA works in any capacity with CMS, but I know that they are the largest provider of telemedicine in this country and have been for, nobody's even close to what they've been doing. And they keep proving every year how cost effective it is for our veterans.
Okay, very good. I'm at the end of my questions. Would you all just like to have a closing comment or question, or glad to say goodbye, or tired of listening to us? Yeah, Dr. Smith.
Congressman, I'd be just happy to first be the one to say thank you for the opportunity to speak about the important matters in rural health. I do think that we are seeing technology both change access as well as quality to care, and as we continue to see this again, as our panel has discussed, as a wraparound person-to-person services, I think we'll have better care for it. The example of, with the VA, for example, CBOX, and how CBOX can actually be co-located with other provider of services and co-supported through technology might just be one more example. So again, Congressman, thank you for this opportunity.
Yeah, Mr. Adcock?
I'd like to echo that. Thank you for the opportunity to come and talk about this important subject. Thank you for your interest and your very thoughtful questions. I do think that telemedicine is a way that we can spread access and improve quality across not just the United States, but across the world, certainly across everything that the United States encompasses. So I think that that's extremely important, and I thank you for your questions and for the time to speak.
It's also great to know not everybody in Mississippi talks like Mr. Keller. Ms. Johnston?
I just want to echo what's been said, but also just from myself, thank you for what you do every day for Americans.
Thank you. Ms. Clowers?
Thank you for having us, and at GAO, we're happy to stand ready to help with any further discussions on this topic.
Very good. With that, we again want to thank everybody for being here. As we heard, telehealth has the ability to connect a patient in a rural area to high-quality medical care at another location. This not only benefits the patients and their families, but also may help the local physician to expand his or her small business. Other small businesses will benefit from dollars staying in the community. Additionally, we have heard that the availability of telehealth may attract new and current physicians to locate practices in rural communities, and also telehealth can benefit small employers and employees by offering convenient access to medical care and monitoring. In fact, I would think it would be an attractive way to attract doctors to the rural area if they know they can do it with telehealth, and the quality of life is coming from a town of 300 people. It's a whole lot better than it is in the city, so therefore, why not move to the country, right? But with consumer demand growing for more convenient and efficient options to access health care, I hope that we're able to sort out some of the barriers our witnesses testified about so that small businesses in rural communities have all the tools they need to thrive and keep residents well. With that, I ask unanimous consent that members have 5 legislative days to submit statements and supporting materials for the record. Without objection, so ordered. You are adjourned.
Thank you again.
Yep.
Chairman Shabbat really appreciates it.
Yeah, no problem.
When we found out Mr. Bloom had to leave. He
Not
was
a problem.
the first person you thought of to reach out to.
I'm going to have to talk to Steve about that.
Thank you again.